Hi, everyone. My name's Dr. Don Buford. I'm an orthopedic surgeon based in Dallas, Texas. I'm grateful to once again participate in an ARMI meeting. Wish I could be there in Nashville, but maybe next time, hopefully. The title of this presentation is Two Conditions Where Platelet-Rich Plasma May Replace Orthopedic Surgery. These are my disclosures, which are also available online. And these are the two areas that I'd like to focus on in this talk. We're going to talk about meniscal tears, primarily talking about degenerative meniscal pathology with or without osteoarthritis. And then we'll talk about lateral elbow tendinopathy, what's commonly known as tennis elbow. Let's talk first about the degenerative meniscal tear, with or without knee arthritis. For the purposes of this talk, we're going to use the Kellgren-Lawrence scale, which is a scale for osteoarthritis on a grade from 1 to 4, where 4 is what's commonly referred to by our patients as bone-on-bone arthropathy. Most of the literature suggests that grades 2 and 3 are where our orthobiologic interventions may have the most effect. And we will go through and see if there's a particular grade or several grades where orthobiologic interventions may replace surgical intervention. One of the things we have to do is recognize where we've been. And before we started really evaluating the natural history of this pathology and the other non-surgical alternatives, this was what I like to call the pre-enlightenment phase in meniscal surgery. What we were commonly taught was that if a patient has knee pain, a meniscus tear on MRI scan, and arthritis on X-ray, then a knee arthroscopy with achondroplasty and partial meniscectomy gives great clinical results. And these patients had arthroscopic surgery that looked a lot like this video where you see some chondrosis on the femoral condyle. This is a medial compartment. You can see on the tibial plateau a little area there in the back where there's a complete erosion of the articular cartilage down to the subchondral bone. You can see the shaver here doing a mechanical chondroplasty. And then also you can see the meniscus being torn, and we can do a meniscectomy with the shaver or with some manual scissors or forceps. But then something happened. We started to look at how many people actually had meniscus tears and were they really causing symptoms. In this 2008 study, published in the New England Journal of Medicine, 991 patients were evaluated with an age range from 50 to 90. Average age was 62. And these patients all got MRI scans on their right knee. What the authors found was that 35% of these patients had meniscal tears. And of that group, 40% were horizontal meniscal tears, which we'll come back to in a little bit. The bottom line was this study beautifully illustrated that meniscal pathology is often degenerative, and there are many, many people walking the streets on this planet that may have meniscal tears that are completely asymptomatic. The level of arthropathy on that Kellgren-Lawrence scale correlates with the incidence of meniscal pathology. So if you have a patient that has KL2 arthropathy on knee X-ray, there's an 82% chance that they have some form of meniscal pathology. If you have a patient in your clinic that has KL3 or KL4 osteoarthritis, there is a 95% chance that they have concomitant meniscal pathology, asymptomatic. 61% of the patients with meniscal tears had no pain. This fidelity study out of Finland, which was published in 2013, is a very interesting study because it actually answered a question that many of us have. What if you did meniscectomy versus sham surgery? Well, they did that. They operated on 146 patients. I should say they had a group of 146 patients split into surgical procedure versus sham surgery. These are all patients that had KL2 or less knee arthritis. As a result, this study was adequately powered. It was well designed. When you look at the charts on the right, you can see that there is essentially no difference in outcome by any outcome measure for the patients that had partial meniscectomy versus the patients that had sham surgery. This lack of difference was carried out for 1 full year. Now, I'm not here to say that this study supports all of us now doing sham surgery, but it certainly is not an argument to continue doing arthroscopic partial meniscectomy either. This 2007 study also looked at arthroscopic partial meniscectomy versus conservative treatment. And this was a level 1 study. It was prospective, randomized. They had 90 patients divided into therapy only or surgery plus therapy, and the average age was 56. Both groups of patients were better at 6 months, but the surgery plus therapy group was no better than the therapy only group. One other interesting finding here is only 41% of these patients returned to the pre-injury level of activity after 6 months. So maybe there's room to improve there, because even the physical therapy patients weren't getting back to their same level in numbers that most of us would consider successful. This study just came out, was just published last month. This was a very large randomized controlled trial evaluating the question of physical therapy versus arthroscopic partial meniscectomy for patients with degenerative meniscal tears. In this ESCAPE trial, we now have 5-year follow-up. And the interesting finding in this study, again, a very large study with more than adequate follow-up, was that there was not a statistically significant difference between the surgery group or the therapy group. X-ray changes, which is another thing that we sometimes talk about, X-ray changes were also similar over the 5-year time interval in this study. So let's move on. We can see that versus sham surgery and versus physical therapy, that arthroscopic partial meniscectomy does not seem to hold any significant advantage in terms of therapeutic outcome. What about platelet-rich plasma for degenerative meniscal pathology? What is the outcome there? Well, in this 2021 study, the authors looked at 69 patients with essentially no arthritis, KL0 or KL1. Their protocol was 4 weekly injections. I like this paper because they quantified the dose. It was a 3 billion platelet dose per injection. And at 1 year, the Lysholm scores were up 11 points in the group over 50 and up 16 points in the patient group under 50. So here was a pretty good study looking at a particular PRP protocol with dosing information showing that PRP was effective with 1 year follow-up. This study is even more specific. This is a 2019 study looking at PRP for patients with degenerative horizontal meniscal tears. So this is the most common type of degenerative tear as noted in a prior study. And now we're looking at a non-surgical, minimally invasive option using PRP as our orthobiologic. 72 patients with horizontal meniscus tears were divided into 2 groups. One group got needling only. The other group got needling plus PRP. They quantify the PRP partially in that it was a 120 cc blood draw and 8 cc's of leukocyte-rich PRP was made. With 92-week follow-up, what they found was very interesting in my opinion and statistically significant. The meniscus healed in 30% of the patients that had needling only, which for some of us flies in the face of what we were taught, that these degenerative horizontal cleavage tears will not heal. Well, here's a study with long follow-up showing that just with needling alone, 30% of them healed by MRI scan. Look what happened in the group that had needling plus PRP, though. 52% of those patients' menisci healed. That was a statistically significant difference with 22 percentage points of improvement over the needling-only group. So adding PRP sure seemed to make a significant outcome difference in this study. One of the other interesting things in this study is these patients were treated just like post-surgical patients that had a meniscus repair. They had to weight bear an extension for 6 weeks, and then they started progressive range of motion and strengthening. And so that's one of the rehab pearls out of this study. So if you're going to do something and expect the meniscus to heal, maybe we should treat these patients with a protocol based on meniscal healing. A higher percentage of patients treated with PRP in this study also achieved the minimally clinically important difference in pain scores and KOOS scores. In the needling-only group, 28% of the patients needed further surgery. However, in the needling plus PRP group, the group that had 52% of those menisci heal, only 8% needed additional surgery. And so the real conclusion here is that adding PRP to the needling significantly increased the healing rate of the meniscus and decreased the need for further surgery, decreased pain, improved function, and also improved these patients' quality of life. So what will it really take for PRP to replace surgery or therapy for degenerative meniscal tears with or without osteoarthritis? Well, in my opinion, if PRP can show a 30% or better improvement in the function or pain scores, that will match surgery or therapy for these patients. And guess what? We're already there based on the data for these most recent studies for doses above 3 billion per injection. Additionally, if PRP can heal specific types of degenerative tears, like this horizontal cleavage tear, which we were just talking about, that would truly make PRP therapy unique compared to partial meniscectomy, even meniscal repair, or therapy. Now let's talk a little bit about tennis elbow. We want to first define what happens when you just treat tennis elbow conservatively, which is what most clinicians should and ought to do in most of our opinions. This study done in 2008 was a retrospective review, and it really illuminated the fact that about 67% of our patients will recover with anti-inflammatory therapy, icing, rest, maybe a brace. This study even included a single steroid injection in their review. It's surprising that there isn't a lot of data on conservative non-operative treatment on tennis elbow just by itself. Let's talk about open surgery. Well, the inertial technique has been around for a long time. It's a technique which is simply sharp excision of the extensor carpi radialis brevis tendon. And this study looks at 10 to 14-year follow-up of that technique for lateral epicondylitis. These authors followed 139 consecutive surgeries, and what they found at the 10-year mark was 84% of the patients had good or excellent results. The single assessment numeric score for these patients was 9 out of 10, and 93% of these patients were back at sport at the 10-year mark. So essentially, that's a good orthopedic surgery. You're getting good results, long-term durable outcomes. Here's another paper looking at arthroscopic surgery. So now we're taking that open procedure and translating it into an arthroscopic procedure. And here's a long-term study showing with Champ Baker's technique that the long-term follow-up is similarly good, just like the open surgery. These authors looked at 42 surgeries, 10-year follow-up, 77% good or excellent at the decade mark, 87% satisfaction, 93% of these patients would do it again. So whether it's open or arthroscopic, the long-term outcome sure seems to be something most patients are satisfied with. There are some new less invasive, and in some cases even office-based techniques to debride the tendon that don't involve surgery or arthroscopy. One example is Tenex, and we have some data using Tenex, which is an ultrasound-based system. It's percutaneous, and it can be done in the office or in the surgery center. In this 2021 level 3 study, 37 Tenex patients with refractory tennis elbow had the Tenex procedure. They were followed up for a year and a half. 11% had to have surgery within 3 months of Tenex. So I think those would be considered treatment failures. However, in the other 89%, their pain and function scores improved and were durable out to 1.5 years. One interesting note in the conclusions in this paper is that patients that had physical therapy after the Tenex procedure had statistically significant better outcomes. So if we're going to be doing Tenex, we probably ought to continue to provide and prescribe physical therapy for these patients to improve their outcomes. Some authors have looked at Tenex versus PRP for lateral elbow tendinopathy. This paper was published in 2019 by some friends, including Ken Mautner and Amadeus Mason and Dr. Gottschalk. And in this level 3 study, they had 32 patients in the PRP group, 30 patients in the Tenex group. They did a reasonably good job looking at the PRP system. They used an IMSITE system with a 30 cc blood draw, which created 3 cc's of leukocyte-poor PRP. We don't have the actual dosing data, but we have a known system and a described protocol at least. What they found was no statistically significant difference in function at 17 months for the PRP group versus 10 months for the Tenex group. Now, they did note a relatively high incidence of additional procedures. 16% in the PRP group needed additional procedures, and 1 out of 5, or 20% in the Tenex group, needed additional procedures. And so we start to get into that question of maybe there's a dosing issue with the PRP, and maybe if we fiddle with the dose, so to speak, we can get a better result with fewer additional procedures being needed. So let's look at the PRP data. Some of the earliest PRP data came out in 2013 in Alan Mishra's study, which was a very large level 2 study. This was a study looking at leukocyte-rich PRP with needling versus needling alone. And what Dr. Mishra showed was a statistically significant improvement in outcomes, up to 84% success rates when you added PRP. So there was about a 16% improvement in outcomes over needling alone. Now, in Alan's study, he followed patients for 6 months. We've had subsequent PRP studies with dosing information and longer-term follow-up. Here's an example. This is a 2022 published level 2 meta-analysis. This is a review of 8 randomized controlled trials looking at the effect of leukocyte concentration on the outcomes. And after crunching all of the data from these 8 randomized controlled trials, the conclusion of the authors was that better results were observed with the use of leukocyte-rich PRP compared to leukocyte-poor PRP in terms of an overall conclusion. In 2018, a nice paper was published comparing leukocyte-rich PRP versus surgery for refractory tennis elbow. This was a prospective study. They had 2 groups of essentially 40 patients in each group. The surgical group had an open excision of the extensor carpi radialis brevis tendinopathy. The PRP group had a 3 cc injection of leukocyte-rich PRP that was made from a 30 cc blood draw using the Zimmer Biomet protocol. All of the patients had at least 6 months of symptoms and had failed 1 prior steroid shot. 13 patients crossed over from the PRP group to the surgery group within the study review interval. These patients in these 2 groups were followed up for 1 year. The primary outcome measure was the PRD, which was the patient-rated tennis elbow evaluation score. The secondary outcome measure was just a routine pain score and a DASH functional score. The results at 1 year, no significant difference in function, no significant difference in the total PRD score. The only thing the authors were able to document was that pain scores were lower in the surgery group at 1 year. But again, that slightly lower pain score did not reflect any significant difference in function. So what will it take for PRP to replace surgery or therapy for tennis elbow? Well, in my opinion, PRP must show near equivalence to surgical excision or Tenex at the 1 year mark, with hopefully few conversions to surgery. And I think we're there. We're certainly very, very close to having that statement be accurate. I think in order to get all the way there, we have to do a little bit more work on PRP dosing for this clinical problem. We need to have a better understanding of the dose response curve for single injection therapy for tennis elbow, meaning that what happens when we deliver 6 billion platelets in a single injection versus 4 injections of 3 billion platelets. That type of clinical study is begging to be done. I think that'll give us the last bit of information to optimize our PRP therapy. And at that point, I think we'll have a very viable, minimally invasive, non-surgical alternative to treat patients with tennis elbow. Well, that's all I've got. Thank you very much for the chance to participate. I hope this raises some additional questions and makes some of you want to go ahead and do some more clinical research and share it with all of us. Best wishes.